Have a good day, all of you. I'm Niluka Subasinghe. Today I hope to discuss pre-excitation syndrome. Here are the objectives of this presentation. At the end of the session, you should be able to define pre-excitation syndromes, identify different accessory pathways, discuss types of pre-excitation syndromes, and interpret electrocardiographic findings. What is pre-excitation syndrome? Let us first consider what is the meaning of pre-excitation. Pre-excitation terms used to describe conductions in ventricular activations occurs earlier than would be expected from activation via the normal conduction pathway. Patients with pre-excitation syndrome have an additional or accessory pathway which directly connects the atria and ventricles. Pre-excitation refers to early activation of the ventricles due to impulse bypassing the AV node via an accessory pathway. I know you have to good understand about normal conduction pathway. Here you can see the first diagram in your left hand side, a normal conduction pathway. Electrical activity in the normal human being when a cardiac action potential arises in the SA node. And from there, the electrical stimulus transmit via internodal pathways to the AV node. After brief delay at the AV node, the stimulus travels to the bundle of His, through the left and right bundle branches, and then the Purkinje fibers, and the endocardium at the apex of the heart. Then finally to the ventricular myocardium. You know, the AV node serves as an important function as a gatekeeper. It limiting the electrical activity that reached the ventricles. This manifested on the ECG as the PR interval. Then look at the second diagram in your right hand side. Electrical stimulus from SA node bypassing the AV node via an accessory pathway or bypass track. Then directly connect the atria and the ventricles. It is an abnormal connection between the atria and ventricular myocardium occurring around the AV ring. Let's see what is the accessory pathway. It's also known as bypass tract. It's an abnormal conduction pathways formed during the cardiac development and can exist in variety of anatomical locations. In this lecture session, I'll hope to discuss two accessory pathways. They are bundle of Kent and bundle of James. As a result of bundle of Kent create WPW syndrome. It's a famous syndrome. And bundle of James may comes out LGL syndrome. I'll discuss it later. WPW syndrome or Wolff-Parkinson-White syndrome. Wolff-Parkinson-White syndrome is pre-excitation syndrome caused by the presence of an abnormal accessory conduction pathway between the atria and ventricles. This accessory pathway is known as the bundle of Kent. WPW syndrome is a congenital heart defect. May be associated with the gene. It's known as PRKAG2. WPW syndrome can be classified into two types. WPW syndrome type A is associated with left side accessory pathway, and type B indicates right side accessory pathway. Now we will consider the history of the WPW syndrome. British physiologist Alfred Frank Stanley Kent invented the bypass tract, And after the different investigations, finally cardiologist Louis Wolff, John Perkinson, and Paul Dudley White created with the definitive description on this disorder in 1930. People with WPW syndrome usually may experience palpitations, dizziness, SOB or shortness of breath, syncope, and supraventricular tachycardia. WPW syndrome is also associated with very small risks of sudden death. WPW syndrome is commonly diagnosed on the basis of the electrocardiogram. ECG features of WPW syndrome: short PR interval, wide QRS complex, strut upstroke of the QRS complex, it is known as the delta wave, and secondary STT changes. I'll repeat again: short PR interval, wide QRS complex, strut upstroke of the QRS complex, it is a delta wave, and secondary STT changes. Secondary STT changes means abnormal repolarization of the ventricle. Now we'll discuss ECG features of WPW syndrome. First one, short PR interval. PR interval is short because the accessory pathway bypasses the normal AV nodal conduction delay and result in premature ventricular depolarization. It's called pre-excitation. Number 2, delta wave. Here you can see this ECG, a green color area is the delta wave. The impulse has reached the ventricles. Onward transmission is through non-specialized conducting tissue, then proceeding a slew on the ascending limb of the QRS complex. This is called delta wave. Number 3, wide QRS complex. The QRS complex is wide since it is the sum of ventricular pre-excitation and normal ventricular activation. It therefore exceeds 0.12 seconds in width. Another one is STT changes. Secondary ST segment depression and T wave inversion are present. STT changes during the pre-excitation. This is due to the pre-excitation leads to abnormal depolarization of the ventricles, and this leads to abnormal repolarization as well. The ST segment is directed opposite to the delta wave. Meaning of the delta wave will be followed by the negative ST segment and inverted T wave, typically with ST segment depression and T wave inversion. Here are the ECG features of WPW syndrome in sinus rhythm. PR interval less than 120 milliseconds. Delta wave, slow rise of initial portion of the QRS complex. QRS complex prolongation more than 110 milliseconds. ST segment and T wave discordant changes in the opposite direction of the major components of the QRS complex. Let's discuss type of the WPW syndrome. Here are the ECG stripped on type A WPW syndrome. Now we can see sinus rhythm with a very short PR interval less than 120 milliseconds. Broad QRS complexes with throat obstruct to the QRS complex, delta waves. Dominant R wave in V1. This pattern is known as type A WPW and is associated with the left side accessory pathway. Tall R waves and inverted T waves in V1 to V3. Negative delta wave in AVL simulating the Q waves of lateral infraction. This is referred to as the pseudo-infraction pattern. Pseudo-infraction pattern we will discuss on myocardial infarction session. Now I'll repeat. Sinus rhythm with a very short PR interval less than 120 milliseconds. Broad QRS complexes with throat obstruct to the QRS complex, the delta wave. Dominant R wave in V1. Tall R waves and inverted T waves in V1 to V3. Negative delta wave in AVL simulating the Q waves of lateral infraction. Now you can see here the ECG stripped on type B WPW syndrome. Here is the sinus rhythm with very short PR interval less than 120 milliseconds. Broad QRS complexes with a throat obstruct to the QRS complexes is delta wave. Dominant S wave in V1. This pattern is known as type B WPW and indicates a right side accessory pathway. Tall R waves and inverted T waves in the inferior leads and V4 to V6. Now I'll repeat again. Sinus rhythm with very short PR interval less than 120 milliseconds. Broad QRS complexes with throat obstruct to the QRS complex, the delta wave. Dominant S wave in V1. Tall R waves and inverted T waves in the inferior leads and V4 to V6. We have to already discuss by this lecture different accessory pathways, WPW syndrome and its mechanisms, type of WPW syndrome and relevant ECG changes. I hope to meet you again with rest of this lecture about re-entry circuit in WPW syndrome, type of cardiac arrhythmias with WPW syndrome, and other pre-excitation syndromes with relevant ECG changes. Thank you for your kind attention.